We will start in a minute. Everything ready as far as you're concerned?
I'm ready.
Okay.
Thank you.
Well, then it's 4 o'clock, so we can start. Hereby, I open this academic ceremony in which Lisa Affengruber will defend the academic thesis Speeding Ahead, Exploration and Further Development of Rapid Review Methods. May I invite you to present a summary of your study and the conclusions of your thesis. Can you unmute?
You can see it, right?
Yes, we can see your
Perfect.
screen, Lisa. Thank you.
Perfect. So thank you everyone for being here today on the committee. I really am looking forward to talk to you today about rapid reviews. First, I would like to explain the challenges in evidence synthesis that motivated my work. Systematic reviews represent the gold standard for summarizing research evidence. Decision makers rely on it to choose effective and safe interventions. They follow a comprehensive workflow to protect validity and transparency. However, this also is the main problem because systematic reviews consist of several complex steps and these take time. Here you can see the systematic review workflow. Researchers first formulate a clear and well-defined research question. Then they search for the studies. Then they screen dually and select the studies independently by themselves using predefined criteria. Then the two reviews come together, they compare the results and resolve the conflicts. This is done to reduce errors. Next, they extract the data and synthesize and analyze the results, and then they publish the findings. Together, these steps often take months or even years, and in many situations, healthcare decisions cannot wait that long. But sometimes we need answers on time. When decisions cannot wait years, researchers start to adapt the process. That's where rapid reviews come in. Systematic reviews are the gold standard and they aim to identify and synthesize the best available evidence. This is highly rigorous and resource intensive. Systematic reviews involve methodological steps, many methodological steps, and require multiple reviewers. As a result, they often take 1 to 2 years to complete. Rapid reviews respond to time pressure with a streamlined form of evidence synthesis. Timely evidence, they provide timely evidence to support urgent decisions, but with some reduction in certainty. They follow a systematic approach, but simplify or omit selected steps. They streamline the steps with fewer reviewers, and these adaptations shorten the timelines from years to even weeks or months. In my thesis, I wanted to look closer at those trade-offs of rapid reviews, and therefore, I defined 3 main aims. To map rapid review methods and tools reported in the literature, to test whether single review screening compromises validity, and to define methodological standards for using supportive software in rapid reviews. To get an overview of the existing literature, we first searched for studies that evaluated methods and tools that accelerate the review process. This work formed the foundation for all later research in my thesis. We therefore conducted a scoping review and we included 103 studies. Around half of the studies were on methods and half of them were on tools. Here you can see the systematic review steps, and that most studies focused on search strategy and literature search, 4 in light blue on tools, and 23 evaluated in darker blue methods. Also, title and abstract selection was very well explored. with 28 tools and 15 method studies. In contrast, only a few studies addressed other steps of the systematic review process. When we look at the reported outcomes, we see that validity was very much evaluated in 46% of the studies, corresponding to 84 studies. 5-year studies examined other outcomes as impact on results, usability, workload, cost, or time saving. Only around a third of studies performed head-to-head comparisons, and only 20 studies evaluated methods or tools prospectively in real-world workflows. One major driver of time and resource use in systematic review is the practice of dual screening. 2 reviewers independently screen by themselves the studies, then they compare the decisions and resolve any disagreements. While dual screening reduces the risk of errors, it also substantially slows the process down. We therefore explored whether single reviewer screening, so screening by only one reviewer, could represent a valid alternative. Our scoping review also revealed a key research gap that very few studies evaluated the impact on results and conclusions. To address this gap, we combined these two and we conducted a study whether single reviewer screening changes review conclusions. We used 3 Cochrane reviews as reference standards. 2 were on oncological topics, case study 1 and 2, and 1 was on a public health topic. Our primary outcome was change in conclusions between the rapid reviews and the corresponding Cochrane reviews. To assess this, we recalculated the meta-analysis and presented the new summary of findings tables to the original Cochrane authors. For each topic, 3 reviewers screened the literature independently, and this resulted in 9 rapid reviews in total. In the first case study, all 3 rapid reviewers identified all included studies. For case study 2, 40 to 60% of included studies were identified, and in the third case study, they identified between 38 and 48%. We then recalculated the meta-analysis and presented it to the Cochrane authors, and this is what they responded. For case study 1, for the first oncological case study, the authors reached the same conclusion for all 3 rapid reviews, as in the Cochrane review. In the second oncological case study, the rapid reviews again reached the same conclusion, but the authors had less certainty into the findings. For the public health case study, this showed a different pattern. 1 rapid review yielded the same conclusion. The 2 other rapid reviews provided insufficient information for any conclusion to be drawn. So validity depends on the topic and on the underlying evidence base. And this method may be feasible for focused clinical questions, but maybe not for public health questions that are more complex. This next study builds directly on the case studies. While the case studies explored conclusions, this study tested screening accuracy more formally. We conducted a crowd-based parallel group randomized controlled trial. We used the Cochrane Crowd platform. We invited participants, 280 persons participated, and screened 100 abstracts each on either a pharmacological or public health topic. Together, they made around 25,000 screening decisions. The analysis showed that single reviewer screening missed 13% of relevant studies compared to 3% of studies when dual screening was performed. The next question is what kind of studies get missed and whether we can recover them. So therefore, we looked at missed studies in the literature. What are falsely excluded studies? We refer to them if they are relevant studies that should be included but are missed or overlooked by the reviewers. And to understand this problem better, we conducted a systematic review. This review examined the characteristics of falsely excluded studies and methods to recover them. We identified only 3 method studies, 2 with a case study design and 1 with a case series design. Our systematic reviews showed that reference list checking of included studies recovered all falsely excluded studies when compared to other supplementary research methods like contacting authors or forward citation tracking. 2 studies reported that up to 8% of studies were falsely excluded due to uninformative titles and abstracts. And 1 study found that 11% of falsely excluded studies were non-English studies. Because this systematic review identified limited evidence, we conducted further research on this topic. We explored the characteristics of false exclusions. We used the subset from the RCT again and did an exploratory analysis on a subset of the RCT. We analyzed 924 inclusion and exclusion decisions corresponding to 73 studies. We examined study characteristics such as study design, abstract content, publication year, country of conduct, journal, and reviewer characteristics. And you can see here on the left histogram that non-randomized studies of intervention showed the highest proportion of false exclusions. So nearly 20% were falsely excluded when compared to interrupted time series, non-randomized controlled trials, and randomized controlled trials. Also, reporting in the abstract played a key role. This was also a finding in the previous systematic review, that reviewers falsely excluded studies more often if study information, we mean population, comparison and intervention, were insufficiently reported, or the study design, so 18 and 15% versus 6 and 9%. These findings suggest that false exclusions are not random. After testing all methods and after exploratory analyzing everything, I now show a practical example of a rapid review. We conducted one on values and preferences. We used Distiller SR as a systematic review platform and also used Microsoft Teams for communication and file sharing. 2 reviewers screened 30% of titles and abstracts independently. Because conflicts stayed below 10%, we then switched to single review screening for the remaining 70%, and this approach saved us about 14 hours of screening time if we say 1 hour for 100 abstracts. 2 rapid reviews are now. Cochrane has developed a whole guidance series of papers to support the use of rapid reviews. And one of these papers is part of my thesis and focuses on the use of supportive software in rapid reviews. In this paper, we summarize all of the findings and all of the knowledge we gathered from the previous studies and mainly from the scoping review. We added practical consideration and developed a framework for choosing and using the tools across all of the steps. The main recommendations are use collaborative online platforms for communication like Google Drive, Slack, and Teams. Use platforms specifically tailored for conducting systematic reviews like Covidence, Distiller SR, or Ryan that enable working in parallel, allow for real-time project management, and centralize the review details. Use automation software to support but not to replace humans or human judgment, and be transparent in reporting of the methods you used and also the potential risks that come with using supportive software. This work has primarily impact for professionals in the rapid review field. My thesis quantified the risks associated with single review screening. The findings show that single review screening can save time and also reduce workload, but it can also miss relevant studies. The results further indicate that abstracts with clear reporting are less likely to be falsely excluded, and the thesis provides an overview on methods and tools that are evaluated, and it shows also that existing research focuses on methods and tools for literature searching and screening, and it offers practical guidance on how supportive software can be used in rapid reviews. It also shows research gaps, like usability evaluations, prospective real-world studies, head-to-head comparisons, and evaluations of multiple methods and tools are needed. It also highlights the potential of hybrid screening models, like the combination of humans and AI. And finally, the findings can inform training and also workshops for review teams, and it also can guide development of supportive software that is efficient, user-friendly, and accessible. Rapid reviews trade certainty for speed, but the aim is to manage that trade-off. My aim is to provide solutions and to bridge the gap between the speed and the quality in evidence synthesis. This thesis therefore provides a framework to navigate those methodological choices and also the software use. in rapid reviews, and most importantly, I hope this research will have long-term impact on how rapid reviews are conducted, so they are useful for decision makers. So now we close my thesis. Thank you.
Thank you very much for your presentation about your work. We will now discuss your work in further detail during the opposition, and the opposition will be opened by Professor Zegers, Professor of Complex Genetics and Epidemiology at Maastricht University.
Thank you, Pro-Rector. Thank you, candidate, for the clear outline of your thesis. I was impressed. I saw that you had your thesis a little bit diagonal on your presentation, that you can see the size, the thickness of the book. This is definitely the biggest PhD thesis I've seen in my entire career. So compliments for that. And it doesn't mean that it's blur. I think this thesis really contributes to the field. I myself, I'm specialized in systematic reviews, and if you have more copies, please give it to me. I will give it to my PhD students. I really like your work. So compliments to that, compliments to the team. Well done. And I start with an opening question, and that's on, just have to get my head across the whole idea of a rapid review, because it doesn't make sense to me. And you end your presentation with trade certainty for speed. And because I'm thinking, don't we always want a rapid review? Who wants to take more time? Is it a money thing? And time is money, yeah? So are we looking for the most price quality? But then I think, but in science, we don't want price quality, we want quality. And because clinical decisions are based on this. And so if we always want to do things as fast as possible, which I understand, I like to do that, why is this a topic?
Yep. Highly esteemed opponent, thank you very much for your kind words, and thank you for your question. Yes, that's a really good question, because I think it totally depends on the decision-making process, the timely needs, and also what do you wanna do with it? So rapid reviews, I live for rapid reviews. I love rapid reviews, but I think it depends. When you think about guidelines or HTAs, I think we want to have the best available evidence, and there are sensitive decisions to be made, and also efficacy and efficiency systematic reviews, where we want all the studies that are out there. So we want the best evidence.
So can you give me an example, maybe in clinical medicine, where we say, okay, I'm happy to trade certainty for speed?
I think, for instance, the COVID-19 pandemic, where we haven't had any evidence, I think it was the best to say we want to have evidence, and the alternative is no evidence. So I think that was the best example. But also the rapid review we did on values and preferences and cost effectiveness, it was a rapid review to inform the clinical guideline, but not for the clinical guideline itself. So it informed the clinical guideline panel, but not the guideline itself. So it wasn't a sensitive topic. So you can, yeah.
Thank you for that. I understand it. And I like to also use that as a bridge to my real question. And that's on chapter 7. Mm-hmm. It's the protocol for your AI tool. So I'm trying to understand that as well. And later I will ask you whether you did a study. But first I want to discuss with you the methodology. Could you explain to me, just in brief terms, the machine learning algorithm that's being used in the TAP phase, so the title abstract screening?
The algorithm?
Yeah, how does it work? Because there is, of course, a machine learning algorithm behind this, and it sorts positives of include or exclude. How does it work, such an algorithm?
Yes. I short explain maybe the idea of the study protocol. We wanted to. It's only study protocol right now. We haven't done it at the moment, but we wanted to test 4 AI tools, Distiller, Rhine, AS Review, and Apple Reviewer, as an assistant for single reviewer screening. We first, this is in the planning phase, we first wanted to do a testing phase where we feed the AI tools 2 decisions from 2 reviewers, and then the AI tools learn from those 2 decisions. There will be conflicting decisions, but this is how it works in real time in the real world also.
Want to elaborate specifically on that step? So this AI tool, how does it learn?
It learns from the 2 decisions that we feed into the tool. So we have planned to upload the decisions from the RCT study, the 25,000 screening decisions, and feed 2 decisions on the same abstract for 300 abstracts, and then the AI can learn. But if those are conflicting, or those are those already missed studies, the AI tool will learn from them and will kind of calibrate to also the false decisions. Yes.
Yeah. So my question goes into, so I have some experience with this in Distiller, not with the other tools that you've mentioned, and there basically you have to set a false negative rate, meaning which rate of which how many studies are you willing to lose in order to use this AI tool. So let's say I'm willing to lose 2%, and you put in 19%. And so now my question comes. So there is some circular reasoning in there. So you set your machine to have a false negative rate of 2%. Now you're going to do your study and you find 2%, of course, because that's what you set. So what are you studying, or what are you planning to study?
So we are planning. We also want to look at those thresholds because I think that's a good point and a really good question, because it totally depends on that threshold you set, and I think there are not a lot of evidence on those thresholds yet. So I think we also have to study that, and we plan to make sensitivity analysis to explore which thresholds work the best and which don't, and where we find the most falsely excluded studies.
Yeah, so what I'm trying to understand is, let's say you put it at 90%, so you might miss 2% of your studies. That's you're willing to accept. That's how you set the machine. Now you find 5%. What do you conclude?
That is a really good question. I think it also depends on what now comes to my mind. I think it totally depends on the context, how many studies are missed and what you conclude. And I think decision makers, one colleague of mine did a study on the willingness of uncertainty that decision makers are willing to accept. So I think it totally depends on the topic, what you're willing to accept in uncertainty. So I think it's always in the context, and also to interpret what studies might be missed and what these risks entail to use these supportive softwares.
Yeah. I think I can see what you're saying, because you say it's like in any diagnostic test, really. Yeah. So depending on the topic, we accept more positive, more negatives, and depending on the percentage that you take. So as in normal diagnostic test, there is a golden standard, and your golden standard, as I understand it well, is the human. So it's machine versus human. That's what you're testing. Yeah? Now, is the human a golden standard? Because I think chapter 3 showed that it's not. So how do you deal with that?
That's a really good question. I'm always, and we are always thinking about that. But what is the alternative? We do not really have another gold standard than the Cochrane reviews or the ARC reviews or dual screening. So I think it is the best gold standard we can get, but it is not perfect, and it also can miss studies. and we have to be aware of that uncertainty. And like in chapter 3, as it showed that also 3% of dual screening missed, 3% of studies were missed. This also comes with the whole process, I think, because then in the end we do reference list checking, we contact authors, and then we might find those missed studies again, or we look at the exclusions again and see. Sometimes it's the case. I also had this experience that we look with other eyes on those studies, because we know the included studies and the studies that are relevant, and then we might find again falsely excluded studies. Yeah,
by just looking at different eyes, I think I can also understand that. So a lighter question and a rapid question, because on the topic of rapid reviews anyway. Chapter 9, you have all these tools. Also love that. Learned a lot.
Professor Segers, your time is up. I'm sorry.
My time is up. I don't.
I want to continue.
Back up.
Yeah, I want to continue because we have a lot of other opponents to ask questions to you. The next opponent is Dr. Bramer, biomedical information specialist at Erasmus University in Rotterdam. The floor is yours.
Thank you, Pro-Rector, and thank you, candidate, for your presentation. Congratulations, as I applaud you with Professor Segers on the quality of the thesis. I've read it with lots of interest, and I think it really contains important research for both me as an information specialist, assisting researchers performing their SRs, also to the researchers performing SRs themselves. I do have a few questions, especially regarding chapter 3, and I do realize it's been quite a while since you published this, and even longer since you designed and performed the research, but hopefully you could still answer this. In your presentation, you focused chapter 3 mostly on the single reviewer screen, but if I'm correct, I think I'm also more interested in abbreviated searches as a searcher myself, since screening 20,000 references by one person would still can take a lot of time. And I think your single reviewers also use the abbreviated searches. As in chapter 4, you see that the single reviewer only results in 13% of negatives. I was wondering, chapter 3, on the selection of you have 3 reviews selected, and I wonder how these were selected. Maybe you can explain a bit about that, because they do not, for me and for other researchers probably, they do not represent the typical reviewers. The review that we see, one review only had 3 included studies, and others had original search results of over 20,000. So how would that that selection process influence the generalizability of the conclusions?
Yeah. Esteemed opponent, thank you very much for your kind words and for this great question. Yes, it were only 3 case studies. First, we wanted to include 4, but then we weren't able to get the included studies and all of the data from the review authors. And we did know the authors from the 3 Cochrane reviews, so they were at the moment ongoing, and we wanted to make it simultaneously, the rapid reviews, that we are not biased. So that was the story behind it. They were ongoing, we knew the authors, and they were 2 on oncological topics and 1 on a public health topic. So I think it's not generalizable. It's a hint in this direction. The findings should be cautiously interpreted, and it would be great to have a bigger data set, to test it with a bigger data set. We also did an abbreviated search with population and intervention, only these 2, and a similar article search in PubMed. And it also worked, but it should be tested with a bigger data set to say it's generalizable. And you can think of it as a proof of concept, but maybe tested with a bigger data set, and also public health and diagnostic prognostic studies would be great, and a whole greater bunch of systematic reviews should be tested to really prove it or not prove it. Yeah.
Yeah, it's interesting that you mentioned the way that you designed that's what you describe in chapter 3, that you design the abbreviated searches as a combination of population intervention and a filter and are supplemented with similar articles. But would you say that would be the best approach for those abbreviated searches, or are there other methods that searches could be abbreviated?
I think there might be other methods that are also a good method. Also in the scoping review, there were, I think it doesn't have to be that drastically. I think it depends on your timely needs and everything. I think also like Yale Mesh Analyzer or text, or also ChatGPT to use for mesh terms, for similar terms. I think that is also a great method to abbreviate the search, or use only 2 databases.
In this case, you also only use one database. You only use that was one that you did in all 3. But what I saw is that you didn't really follow the methodology that you described. If I look at page 180, where you describe the abbreviated searches. In case 1, you combined the results from the similar article feature again with an intervention search and didn't add a filter. And for case 2, you added other elements that were neither P nor an I, and in case 3, you did not search population or intervention, as this was not a therapeutic research question. And then it results, I think the searches were developed by our colleague, Waffen-Smith. And then you're, depending on the quality of the information specialist and the nature of how they do their search. So what we as information specialists would want to see is a good protocol there, because if I look at these searches, slightly over a year ago, we had in the same university, but the thesis defense by Melissa Ratliff, and many of the committee members will remember probably. And one of her spare points was that in searching, it's important both the correctness of the search and the repeatability. And if you look at those searches as they were done in chapter 3, were they indeed correct, and how repeatable do you expect them to be?
Yeah, thank you. That's a great comment, because I'm not an information specialist. I do not really know if it's reproducible, but that's the point, I think. If it's reproducible, and if we would find the same studies again, or if not, yes. I think that's also really important also in rapid reviews, to report and be transparent of what you did in your protocol and what you're planning to do. And changes should also be made transparent if you do so. Yeah.
Yeah, I think in this case the searches were not reproducible enough, and the relevance ranking which is used is undergoing major changes, and the automatic term mapping as well. So if you want to continue, I would like to see that we do it. And what I often use is for instance, using major mesh terms combined with searching the title. That would be a good new approach. For the rest, I was wondering on chapter 3, you used for each review, you used 3 references in the starter set. Could it be that maybe those three reviews were ultimately already leading to the 3 included studies and making it an expectation that indeed 100% of case 1 would be found?
Yes. Yes, thank you very much for that great question. You're totally right. These starter sets might have led to those 3 studies, and also to those 10 and 21 studies that were included. I think that's also a limitation of this. But I think also that from the perspective of a rapid review or systematic review, most of the times we have those 2 or 3 studies that are highly relevant. So I think it's a limitation for this study, but in regard of a real world workflow, I think we would have that normally.
I'm hoping that we're not losing on quality, because I've always been taught. I did a PhD with the same supervisor. Jos Klein was my supervisor, my promoter as well. But I was always taught that as an information specialist, you aim to retrieve 100% of publication, that publication, not just study. And now I see in chapter 3 that you aim to find all studies and not publications. Are we not downgrading the systematic review? You quote John Ioannidis. I think you will agree with me that enough enough high quality systematic reviews are already published. Who's waiting for low quality systematic review?
Yeah, that's totally true. Yeah. Yes, we analyze publications and studies, and we thought of it as if we find one publications, that we also find the studies, because through referential checking and so on. But that's you're totally right. That's also a limitation of that study. It's the findings should be interpreted with caution. Yes, it's only a hint in that direction, I would say.
Okay,
Yeah.
Thank you, Dr. Bramer. The opposition will be continued by Professor Hoofd, Professor of Evidence Synthesis and Knowledge Translation in Healthcare at the Julius Center, University Medical Center, Utrecht.
Yes, thank you. But first, dear candidate, I would like to congratulate you and your team with your beautiful thesis. I read it with great pleasure because it touched upon a very important topic of our work. The development of the rapid reviews, you discussed already many questions on this topic and the use of AI tools in evidence synthesis. So as you know, I'm the director of Cochrane Netherlands, so I need some actionable advice from you, as you are now one of the experts in the field. So my first question is on the use of the single reviewer screening. And we are in the midst of a huge diagnostic test accuracy review. And we need to do it not with 2, but with 3 people, new regulation. And I want to dismiss that. I want to go for the single reviewer screening stage because it saves lots of time. So you have done a couple of studies about this, and I am wondering, can you propose to me some sort of a decision framework which I can use, which specific characteristics, depending on the rapid review type, are correlating with that I can safely use the single reviewer stage?
Highly esteemed opponent, thank you very much for your kind words as well, and thank you for your great question. Regarding recommendations, of course, I can say something on that. We also did the values and preferences rapid review, and I think it would be great, and also the guidance for rapid reviews was also updated, and we have in there that single screening is recommended if you do first dual screening of the 20 to 30%, and then you look at the conflicts. And if the conflicts stay below a threshold of 20%, then you can move on with single review screening. And I would also recommend, I did it in the rapid review of values and preferences. I also checked the exclusions, and maybe also check the exclusions with AI. But we are at the moment testing it, but I think Distiller or Daisy would be a great tool to check the exclusions and verify that and let it predict if it, and look at them again.
Yeah.
And also maybe incorporate some supplementary research methods like reference list checking or forward citation tracking or contacting authors. Yes. Depends on your time and the context and the topic.
Okay. In the last wordings, I think there were already a little part of the answer I was looking for. So first you say, do not start with single screening at all, but do it with your co-pilot or with your AI tool to assist you on this. So that's, I think, good, well noted. But then you very quickly answered with, oh yeah, there are some contextual factors. can you elaborate a little bit more on that? So do you know already upfront, yeah, if you are diving into this field with this study design type, don't do it at all with only with one reviewer, or the other way around? Yeah.
Yes, I think it depends on various factors. So first, I think who commissioned the systematic review or the rapid review, I think it should be communicated with the decision maker or the commissioner what the budget is, what the timeline is, what the question is. If it is a sensitive topic and you need all the evidence, I think I would stay with dual screening. It has less risk of missing relevant studies. If it's communicated and you decided to do single screening with your commissioner, I think that's fine. And first, you also have to test it first. For instance, distiller Daisy, is it available at your university? Is it? Do the reviewers already know it? Do the review teams have had training on it? I think that also depends on your review team, on your institution, and also if it's a guideline or if it's an HTA, I wouldn't recommend doing it because you want the best available evidence. If it's communicated and you do a systematic review, I think it's totally defendable to do it like that.
Yeah, so I'm very happy that you can give me some frameworks or questions to think about whether or not to go for a single stage reviewer. And maybe it's also nice if we dive into the features of the review topics together, because maybe we can also come up with heterogeneity in study designs, for example, or the intervention types. Maybe there's also some correlation, or the outcome diversity. So maybe all types of features, depending whether or not it's doable to do it with one single reviewer. Because then I wanted to ask you in this line something about the root cause of missing studies. So you identified that it's primarily due to poorly structured abstracts. But your complete thesis is on AI tools. But is that the best intervention to improve the root cause? Or can you come up with different, maybe more cost-effective interventions to change this? So my question is, should we improve the AI tools to deal with the poorly abstracts, or can there be other interventions?
I think both. I think first I would try to improve the abstract quality, that they are structured, and study information like population intervention comparison and study design is sufficiently reported in the abstracts. I think that authors should adhere to reporting guidelines that would be very helpful for reviewers.
Exactly. Yeah.
And also, I think journals, peer reviewers, and also authors should adhere to that and check this if this is done sufficiently.
Yeah.
And then also the AI tools. Yes, I think when you use AI tools, they need a good training set, and to make sure that the training set is good and it learns well from the training set, and also that the reviewers are well informed, that train the AI, that they are calibrated. If you use 2 single reviewers, that they are calibrated, that they understand under the same terms the same things. Because sometimes in abstracts there are terms used that are topic specific, and maybe also focus on the inclusion and exclusion criteria, that all the terms are used, and that you have a discussion about it, what can be used and how an abstract that is relevant can look like, for instance.
Yeah, I completely follow you. So you talk about training, regulations, or more or less standardization. And I also was wondering, because you mentioned the checks with the journal. So maybe here is also a role for AI to automatically check whether or not the abstracts adhere to the reporting guidelines. Yeah. one question in between. No, not in between. It's the last one or not?
Very short.
Yeah, very short. It's a very short one because you also identified that the reviewer characteristics had no significant impact on the accuracy. That was a little bit surprising. Can you explain very briefly why our experience does not help us?
I actually, yeah, that was very surprising to me also because there were some hints that researchers, for instance, faster falsely excluded studies than other healthcare professionals. So that, yeah, I think maybe we sometimes overestimate us. I don't know.
Yeah. I think in general, people are overestimating themselves, but I think that's a good last sentence to go. Give the word back to the dean. Thank you.
Thank you, Professor Hooft. The opposition will be continued by Professor van der Weijden, Professor of Implementation of Guidelines and Shared Decision Making at Maastricht University.
Thank you, Prorector. Can you hear me well? Yeah, I would like to echo the compliments that Professor Segers and the others already made. It's such a heavy thesis. It's impressive. So compliments also for your supervisors. And I think it's so needed that you give evidence to the world to prevent our policymakers or patient advocacy groups or whatever, they might no longer want to finance all this systematic review work. That's my worry a bit, because they think, oh, we have Gen AI tools and they can do it in a cheaper way. Is it, by the way, this is outside your thesis actually, is it a threat in your vision already that we will miss out on grants or to make, yeah, is it already happening?
I think that some review teams might do not know the risks of those AI tools, that they really kind of use it as a safety net. And I think you always have to be aware of that risk of missing relevant studies, and also that it should not be a safety net and should not be a replacement of a human judgment of humans.
And not a replacement of the human work. I like your proposition 3. So these AI tools, they claim to improve rapid reviews, but too few have been tested in real world workflows. Such an important proposition. So we should all use it in safeguarding a good systematic reviews. For me, it's been a while to be really into the world of systematic reviews. I'm now more in shared decision making, and chapter 2 was amazing. So many studies. It's 103 included studies, isn't it? And it's over 100 pages. I was really amazed that on page 39, I saw things like for critical appraisal of studies, we can use robot reviewer, for example. And it was even in your chapter 9, you recommend it in a way, although, but then that's a question. Did I understand well that you do recommend it, but for RCTs, for reviews of RCTs only?
Yes. Highly esteemed opponent, thank you for your question and your kind words. To be formal, and yes, I think robot review is well evaluated for RCTs, and it can extract the data well for RCTs, but for other study designs, it is not really working for complex study designs. And I would use it as we used it for RCTs, and then a human should check it.
Okay. Yeah, it's also in your proposition that you really should be more wary for more complex interventions. So make sure that that's clear to the world that for RCTs only. But if then what was in your appendix of chapter 2, it's on page 133, and it's what's puzzling me. You learn that less experienced reviewers were generally more positive on use of robot reviewer, and they saw more benefits and were able to use the tool more flexibly than experienced reviewers. I think Professor Hooft, she already addressed it too. So how come? how come that the less experienced, are they not judging the robot review tool well?
I think yes. Yeah, it could be that less experienced reviewers are either not maybe aware that they kind of miss data through it. And I think experienced reviewers might already be a little bit more aware of the risks of supportive software and that we also need a human in the loop that has to check. But I think it's can be used as a supportive, as an assistant. It is great for that, but it cannot replace a human.
Yeah.
And sometimes we think of AI or those algorithms or machine learning kind of this holy thing, but we have to check and we have to be aware of that risk.
There might be another threat then, that less experienced reviewers, that they compete with you and they claim, oh yeah, we do it but much faster and cheaper and we use robot reviewer. So I think that's also a threat that we have to, in disseminating all these tools, we have the impact that we really want. If there's time, as a very short question, last question on this is chapter 8, which is more in my expertise. And congrats with publishing in Annals of Internal Medicine. It's a beautiful journal. It's not easy to get in this journal. Let's try to phrase my question in a short way. I learned that the variety in patient preferences is actually more informative than what is the major preference that patients have. To put it differently, where is the page? Should your research questions, and then I go to page 8, which was like your research question was, what values and preference do patients have regarding depression management? Should it not have been, what values and preferences do informed patients have? And with informed, I mean patients are informed on the various guideline recommendations and the pros and cons. And that's the type of research that we should do. Can you reflect shortly on that, please?
Thank you for that great question. That's a really, really good question. Yes, I think that is really important that patients should be informed about the various preferences and values that are out there. And it was my first values and preferences rapid review and systematic review. I haven't done it before, but it was really, really nice to do it, and because it was a qualitative way, and I haven't done qualitative research before in that area, and it was really, really nice to do. And yes, I totally agree. I think it should be that way. Yeah.
Well, thank you for having this chapter in your beautiful thesis. And I've really learned that informed patients, they actually develop other preferences than the less informed patients. I'm very happy with your answers. I give the word back to the pro-rector.
Thank you, Professor van der Weijden. We now come to the last opponent. That's Professor Burgers, Professor Promoting Personalized Care in Clinical Practice Guidelines from Maastricht University. Professor Burgers.
Thank you. Dear candidate, I have read your dissertation with great interest. It's not only relevant for reviewers, but also for guideline developers and guideline funding organizations. I'm also very impressed by the large number and variety of studies in this thesis. 7 out of 8 chapters were published papers, and that's a great achievement in a limited period of time. So again, also congratulations to you and your supervising team. My first question concerns the use of rapid reviews in clinical guideline development. As you may know, I'm affiliated with the Dutch College of General Practitioners. They have a large, long-standing guideline program, including approximately 150 guidelines. And most of the work concerns the updating of the guidelines, which is performed by a team of 50 staff members. And we aim to produce 10 to 15 updated guidelines a year. And each guideline has approximately 10 PICO questions. So in total, 100 to 150 literature reviews annually. So, and we already apply rapid reviews methods. Systematic reviews take you 1 year, and a rapid review maybe 6, 8, 10 weeks. So we need to do that. So we are restricting the search to systematic reviews and RCTs under the principle good is enough. But it's still a tremendous task and a challenge to balance time and quality. In your thesis, you conclude that in public health decision-making, you also need to capture context and complexity. It was also mentioned by my colleague. But how do you do that? And does it also apply to primary care?
Dear highly esteemed opponent, thank you very much for your kind words and for your great question. I think so. Generally, for clinical guidelines and also HTAs, because you want to gather all the best available evidence available, I think rapid reviews I would not recommend them, but there are also supportive software that make the process more efficient, like distillers are to have a platform where you gather all your systematic review. You manage it, and you can also use Microsoft Teams and those communication tools, and also OneDrive and Teams for file sharing and so on. But if you say you are updating systematic reviews and you actually have the database of included studies, I think you can also think about single screening together with AI and test it in your own environment and test if those studies maybe are all captured, because you have these big data sets of included studies and relevant studies. I think that would be a great shot to do that.
Okay, actually, this is the answer on my second question. How could we do it still rapidly? But my first question is more also on the clinical content. So we do have a rapid review, but how do you capture the context and complexity? Yeah.
Yes, that's a really good question. How you can capture it? I think it is. Yeah, that's a good question. We also thought about that. It's really hard to capture complex public health interventions. And I think it's also a challenge to capture it because they're also differently.
So what we do in clinical guidelines, we have a guideline panel with expert opinion, and also including patients. So, and that's also the definition of a guideline. It's a literature review, but you also include the opinions of experts. If you do not have evidence or of low quality, we also ask the experts, the clinical experts and the patient representatives. So that's how we do that. And that's why we still need a panel. Yeah. But again, we apply rapid reviews, but how can we still speed up the time and get our full guideline program up to date? See, you're the expert, so I'm looking forward to your recommendation. What can we do better?
So I think what you can do better, what is to have all the best available evidence in total, and also speed up the process. I think for project management, you can use those tools. I think for the communication, for file sharing, for doing the things parallel and from anywhere on the world, you can work together. So I think those software tools that do not use AI, but also make it more efficient, I think I would recommend those for.
Yeah. What's your opinion about the new developments on generative AI? Because the quality of generative AI has improved much in the last year. I think your study stopped in 2025. what's your prediction on the future? Because I've heard people talking about generative AI tools like ChatGPT and Gemini, etc. They say they can take over all the human tasks. Of course, you have the human in the loop, but the tools are so intelligent and are so fast. They could take over. Do we still need information specialists, for instance? So could you tell us what's the future about 1, 2, 3 years?
From my point of view, thank you for that great question. I think from my point of view, it is a great opportunity, I think, to involve and implement those AI tools, but I think at the moment, they are not quite well evaluated.
Lisa Affengruber, the time appointed for defending your thesis has passed, and the degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company online await the results of our deliberations and our return. Lisa Affengruber. The degree committee, here present online, has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Kleine is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee, I here present online, I hereby confer upon you, Lisa Affengruber, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate, signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university, shown by the beadle.
We now continue with the laudatio, which will be given by Professor Kartlener.
Yeah, thank you. Esteemed members of the PhD committee, dear colleagues and friends, and above all, dear Lisa, it is a joy and an honor to offer this laudation. Today we celebrate not only a PhD, but also a scholarly journey. Since 2017, Lisa has been a pillar of our research team in Krems. She brings structure, makes methods usable, and remains unflappable when timelines tighten. And when it matters most, Lisa shows up reliably, collegially, and solution-oriented. And as we've heard today, Lisa's PhD topic focuses on rapid reviews, so evidence synthesis delivered very quickly. And those of us who work in this field often struggle to explain to non-researchers what that actually means. But Lisa's husband, and I'm not sure if he's here, Lisa's husband, Manuel, uses an excellent shorthand for our work. So when asked what the topic of Lisa's PhD is, he simply says something rapid. But no PhD is actually a rapid sprint. It is really more a long distance run, also for Lisa, because journals found it difficult to find peer reviewers. One of her papers kept getting sent back, and in the end it took more than 3 whole years before the paper was finally able to be published. Lisa's professional development, however, really tells only a fraction of the story. Alongside research, Lisa became the mother of 2 sons, Jonas and Nino. Balancing research, family, and everyday life requires organization, stamina, and grit, all qualities that Lisa embodies. And if you've ever wondered where her rapid reviews get their energy, I can also tell you from my own experience, life with 2 young boys requires very rapid turnaround times. But Lisa's not only a researcher, she's also a fitness trainer, and together with her husband renovates and manages apartments. So evidence synthesis by day and a business owner by night. And a laudation would be incomplete if it stopped at methods. Today is also a moment to thank those who stood with Lisa. Manuel, her husband, for constant support and of course for coining something rapid. And also her parents, Anna and Peter, whose steady encouragement and babysitting have been an essential foundation for her success. Lisa, on behalf of the entire team at the Department for Evidence-Based Medicine and Evaluation, a heartfelt congratulations on an outstanding achievement. We are all really proud of you and looking forward to your return after your maternity leave. Congratulations, Dr. Lisa Affengruber.
Thank you so much for those kind words. I'm getting a little bit emotional because it was a really long journey, and I'm really happy that it now comes to an end. And I can focus on other things. Yeah. Thank you so much.
Dear Dr. Affengruber, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. I'd also like to congratulate your family, your husband, your children, your colleagues with whom you've worked and who have contributed to the work you presented today. I'd like to congratulate your supervisors, Professor Kleine and Professor Gartlener. I'd like to thank all the members of the degree committee for the time they have invested in preparing for this ceremony, especially our guests from outside of Maastricht University, Professor Hoofd and Dr. Bramer. Thank you very much. It's unfortunate that you couldn't defend your thesis live here in Maastricht, because that's always much nicer. But nevertheless, I hope you enjoyed the defense. I wish you a very enjoyable rest of the day and a successful, you showed that you have successfully ended your PhD trajectory today, and now it's time to think about other things. I hereby declare this ceremony for ended. Okay, well, we can now